This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
Welcome back to another edition of the Owens Recovery Science Podcast. This is Johnny Owens, your host, along with Kyle Kimbrell out in LA, co-host. And today we got my friend Brad Lambert on from Methodist Healthcare in Houston, Texas. Brad and I have known each other for several years now. I was trying to remember, Brad, we first met, you came to the Center for the Intrepid, I think it was around 2015 or something, when we first were kind of discussing.
Trying to copy your lab ideas there.
Yeah, well, you've done a good job, man. That's for sure. So why don't you introduce yourself, Brad, and give a little bit of background. We're going to kind of go into a deep dive of what you're doing. You're doing some badass stuff with blood flow restriction right now and any other topics.
Sure. So I, after getting a bachelor's in kinese from Texas Lutheran University, I ended up wanting to go further than that. I was always very interested in sport training, and particularly skeletal muscle plasticity. So in other words, the way that muscle adapts to different types of stimulus. So I went to grad school at Texas A&M, where I did a PhD under Steve Krause, and had a great team of not only applied scientists, but also very good basic scientists in muscle physiology, where I got interested in this concept of muscle interference. So in other words, conflicting signaling, whether you're doing endurance training or resistance training, that governs how you adapt to those responses. It's a very big interest of mine, because as a young 20-something, you're always like, why can't I just train for everything and be the best at everything? And then it gets more depressing as you dig down into that line of research. So in other words, looking at how muscle adapts to very specific responses. And as far as kind of for the present talk today, I think it was a few years into my PhD work that a researcher named Blake Rasmussen came and gave a talk at our seminar and started discussing what they were seeing early on with blood flow restriction. And Johnny, this might have been around the same time you were maybe down there in that area. So it was becoming a fresh new topic, because we were finding increases in muscle anabolism, and nobody really knew why at the time. It just seemed kind of interesting. And it was another case of where you have people on the front lines and athletes kind of figuring something out, and then the scientists chasing to try to catch up and figure out the why and where it could be applied. So then after I went, I was interested in that type of work. I was interested in stable isotope tracing methodologies for things like protein synthesis. So I went to kind of one of the main places to go to learn about those kinds of methods, which is UTMB in Galveston, out of the group that where Bob Wolf kind of as a legend kind of pioneered a large portion of the field. So following that, I was off. There was a researcher at Texas A&M that I had known, because funny enough, he had been a participant in my training study when I was doing a PhD. He was an engineer, biomedical engineer, and we always joked with each other about why our fields weren't interacting with each other more, because they were kind of over on one side of campus and we were doing our thing on the other side of campus. So his name was Mike Marino, and said, hey, I think we might be working on setting up a lab at Houston Methodist. So I was given the opportunity to come work with orthopedics and sports medicine here with some of the best physicians in the country for very, 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 very interesting injury types and rehab programs and things like that. So I jumped at that chance, and also the chance to work with athletes again, and got here and started setting up a lab. And then since then, I've kind of been more hired on full time at Methodist, because I was kind of split time between Texas A&M and Methodist. And now the lab, the Orthopedic Biomechanics Research Lab, functions as its own kind of entity here in orthopedics and sports medicine, where we do everything from biomechanics following getting a total joint replacement to looking at rehab outcomes and or different types of implant device design. We also do sports performance testing, and then we also work with our folks over in the Research Institute for biologics and more basic basic science type studies as well. So a lot going on. But that kind of gives you a general overview, I think.
It's amazing what you've grown in like 5 years when we first met. I mean, it seemed like the lab was just kind of really starting to happen. And now it's like the big beast that everyone's competing with in the largest medical center in the world, the TMC in Houston. So kudos, man.
At this time, it's more just trying to field all of it's awesome because we get a lot of studies in a lot of direction. The lab also functions to field research questions coming from our own department. So in our department, all the fellows and residents and even interns are expected and required to do research. So it's not like it's not a hobby for anybody. So the lab ends up being highly integrated with all of those different questions. So we kind of have to take them from all comers, and then from on the BFR side of things, we also have to take what's coming into us from the sports community, because professional athletes are interesting characters in what they decide to go do sometimes training wise. So then we have to assess, okay, well, what are they doing? Why are they doing this? And does this even work and make sense? So, we're never, even though the country's been kind of shut down, we've kind of been trying to use this time as catch-up time to get some of these papers off our plate and get some of this stuff out. So kudos to the skeleton crew, all of our coordinators that have been able to do this. It's been an interesting, this whole situation's been interesting without having our usual students that we have in the lab.
Yeah.
Kind of workhorsing things for us.
I think we're all in the same boat, and we just finished the DoD grant season. So that was the beast that was also on the plate. So, and I just want to point out too, we have the Techniques in Orthopedics special edition that was only on blood flow restriction that I was one of the editors on. And so you were one of the first guys I reached out to because we wanted to do a paper in there just on what we knew from the muscle protein synthesis side with blood flow restrictions. So if you go Techniques in Orthopedics, pull up Brad Lambert. He wrote a great paper. I reviewed it and it was awesome. So you kind of want to go into that. And when you were down at Rasmussen's lab, were you actually working there when they were doing some of their initial BFR stuff, or was that after?
So I had gotten there just after that, and interestingly enough, they had brought back one of the guys that had done a lot of work in that area, and he's an amazing researcher in muscle metabolism, and his name's Chris Fry. Mm-hmm. And I would look up some of his work on not only blood flow restriction, but satellite cells and I mean everything. The guy's a genius. So
yes.
So I got to spend a lot of time talking with him about those studies, and that's actually contributed a lot to helping me kind of work on that paper. Additionally, in that paper, I also want to point out our one of my co-authors, Corbin Hett, who's kind of our boots on the ground on the PT side over here. He's doctor of physical therapy, did a great job of also kind of transitioning in that paper from, okay, here's kind of what we learned on the basic science side, and here's how it's now being applied clinically. And because those are the guys that get to try to make sense of all the stuff we do in the lab.
Yeah.
So. Yeah.
Well, check it out if it's out there. And I agree, Chris Fry's a stud, man. So he's at Kentucky now. I don't know if you know, he left. Mm-hmm. But we're involved. He has an ACL trial up there that we're involved with him as well. So yeah, anytime we can work with him, it's good stuff. So
Brad, I have a confession to make, if you'll permit me, because we reference your paper a lot when we teach. But I always tell people to grab a cup of coffee before they dive into that bad boy. It's dense, man. Holy smokes.
There's a lot in it. And what we try to do in that paper is kind of try to separate out, I think, some of here's what we know, and here's kind of the stuff that is being hypothesized, but at this point is still a little bit hearsay. So I think that kind of going through each of those bullet pointed items it takes a minute. And then also some sort of, that's why I put that giant convoluted figure in that paper and that big signaling figure, just more or less to show everybody like, hey, this is not exactly something that's just you get from point A to point B type thing.
Yeah.
So, yeah.
And I think that's so important, I think, in our world to really kind of know and kind of say, look, we think we know these things, but there's a lot of this stuff we're talking about we don't necessarily know exactly,
Right. And I think sometimes that gets lost in translation from the paper to when I'm talking to some random guy who's got straps on in the gym. But I always like them to teach me about it first, because it's just interesting to hear, what's your current understanding of why you're putting these on yourself at the moment.
Is there any description that stands out in your mind in terms of what's been described to you?
Well, I think one of the biggest things that that you hear a lot is this idea that, if I put this on my leg, I'm just going to start spewing testosterone and growth hormone out everywhere, and it's going to make me grow into this giant muscular thing. And I think those are the kinds of things that we're trying to kind of tame a little bit, because where there's probably some seeds of something in there, but also just it's explained to people that we're not doing magic here. It's not muscle alchemy. It's trying to get into a little bit of a better understanding of it. But I was kind of, when folks just start describing it, I kind of want to hear how it's being translated out. Particularly to the average person, because now we're starting to get into this place where it's leaving the clinic and going into somewhat of a performance realm.
Yeah, I agree, man. And we deal with those either emails or direct questions, I think, on a daily basis, man. So I can't tell you how much testosterone and growth hormone I've rolled my eyes at, because that's pretty much all we're hearing anymore.
Yeah.
Yeah, like that. And then, I remember back when there's still a big thing, but like when exercise and cytokines was like a really, really hot topic, and still is to some degree. But we had a researcher at Texas A&M literally getting phone calls because he did a paper on IL-15, asking if people could inject IL-15. So it gets a little bit nuts, I think.
Yeah. Well, I guess let's kind of get into the nitty gritty, meaty gritty, whatever, man. I'm hungry.
Is that a fiddly bit?
Yeah. So maybe mechanistically, what you're going after, we talk about it all the time on this podcast, but what you're going after from a BFR perspective, say a post-op patient, post-op ACL, post-op TKA, your thoughts on timing of this, your thoughts of occlusive pressures. I know we speak the same language as you, but
right.
Just want to get it from your mouth.
Right. So I think the main thing that we're trying to do, that everybody's trying to do following ACL, is get people back safely and quickly, right? So we want to minimize atrophy. We want to minimize loss of function in the limb. So if you can do those two things, then the general consensus is that you can get back a little bit faster. I think so if you can stimulate kind of those acute anabolic processes and stave off some of these post-operative catabolic issues, then I think it puts you ahead of the game a little bit. And as far as timing, here at our clinic, we have people that are starting within the first week after surgery.
Yeah.
Simple things like quad sets. And a lot of this is recommendations from you guys, because you guys have done a really good job of taking the lit that's out there and applying it in a practical way for PTs to actually make sense of. Starting to look into it a little bit of this concept of prehab before surgery as well. Can we just kind of, even though they're injured, can we just kind of cause enough of a stimulus before they're about to be unloaded for a little bit? And I really do think there's something interesting that happens between the time of injury and then if you see somebody right after injury, it's a lot different than when you see them right after surgery. You see ACL guys come in right after injury, and they actually sometimes don't look that bad. Mm-hmm. So you have a trauma, and then you give them a second major trauma by performing surgery on them, right? So then you're kind of doing a double insult to the limb. And I think that's where the big challenge is. I mean, in a 2-week time span, you can see people losing like a half kilo in a leg, just from the unloading effects of that. So right now, the general approach for our lower limb, as we kind of follow your guidelines that Owens Recovery Science puts out, is the 80% occlusion in the lower limbs as tolerated, and then 50% occlusion in the upper extremity. Interestingly enough, it seems as though while that's not always the most comfortable thing for patients within the first, I'd say, week or two, the one interesting observation we have is that by about that third week, they tend to not have as big of an issue with the compression in terms of discomfort. So far, it's been generally, we found it to be pretty safe. In older populations, I know what Corbin and those guys are doing sometimes is starting people at slightly reduced cuff pressures and then kind of going as tolerated. I know in the lit, you don't have, it's the lit's pretty suggests we don't have this like magic threshold, and that even at some lower cuff pressure, you still get a nice benefit from using them. So that's kind of helpful for some folks that may not tolerate those things as well.
Did you have any issues initially with your docs moving forward with this? Concerned about anything or concerned about starting early? Because
to be honest, when we started getting in on the ACL side of things, Dr. Pat McCullough and then Robert Jack as well here, and I know Dr. Harris in our department as well, they were actually kind of the ones that were pushing for it a little bit, seeing that it had some beneficial effects. There didn't seem to be really any apprehension, particularly with anyone going into it. So it very quickly after, like in the midst of us getting started on the study, it kind of became a standard of care item for most of our clinic. And a lot of that is Corbin and Corbin Het, and also our head of physical therapy, Matt Holland, really kind of working on this, because they're the ones who get to hear all of the, and it, you know, as researchers, we take direct measurements, right? And that's the stuff we report on, but they kind of get to deal with the patients day to day as well. So they've really had no issues, and they've been following the guidelines. So
Matt Holland has the honor of being my first certified provider for an open course. I'd done multiple privates for the teams, but Matt was the first one I did when I did my first course, and he was the only person at my course.
Well,
it was me and Matt.
but now look at where it is. All you needed was that one guy, and
I just needed Matt Holland. Yeah, man,
that was the thing.
Poor guy. We just sat in a room and talked. That was basically what the course was, because there's no one else there.
Yeah, well, but that's kind of, I think, but as far as getting into it, there wasn't really this big apprehension. I think the folks that we're having to do some convincing now with might be more on the older patient side, particularly in the joints area, joint replacement and things like that, because there's just so much that rides on those kind of first weeks as far as their general timeline and implant success. And so the timelines may be a little bit extended there. It's something we eventually would like to look into. But I think seeing who and how these things, who can benefit and how these things can be modified for older participants is kind of where we're at orthopedics wise now, because on the sports side, as far as rehab goes, particularly in the stuff that's distal from the cuff, I think most of our physical therapy crew is pretty sold.
Yeah. And I would say, like you guys are definitely, early adopters, have been doing it for a while, and all these groups that have a lot of comfort level. I think we're still with the total joints. There's that question, when would you start on this older TKA?
And then it's also a different mindset of people, right? Because
for sure.
they're not worried about getting back onto the field to run the 40-yard dash.
Mm-hmm.
They're just trying to kind of get up and get moving again. So the question is, does that involve them having to come to the PT clinic twice a week and then do this and that? I would say my answer to that anecdotally would be, it depends on the type of joint replacement patient you're dealing with. So I would say you have different you have folks that are kind of getting a total joint replacement because they're in pain and they just to be able to ambulate. And then you get people who I get pain when I'm out golfing for 3 hours.
Right.
And I've got an osteoarthritic knee, but I'm still very, very active and I want to maintain that level of activity. So I think it really depends on how we target the right people for that intervention.
Yeah. But I hope we kind of see this progression where we're getting those kind of hard chargers that we know we need to do it a little bit more. And then, kind of like we got some new vascular stuff where we're starting to see it with some of these oxidative stress people where we're focused on the vascular system. Then maybe it is rehab for these total knees. The outcomes might be better if you take this sarcopenic elderly female who would maybe they're just going to cut her loose after that. She might really benefit from
certainly. And
exposure.
I think even like in the later periods, starting them at potentially 3 to 6 months post-op, because they're still getting follow-ups at a year. And keep in mind, most of the people that are getting these joint replacements, most of these women are postmenopausal as well. So you have all sorts of other things that might challenge bone. Yeah.
So do you have a joint trial still planned? I know we talked about one in the past, or is
we're trying to do some convincing now. I think anecdotally we're in the middle of trying to collect a little bit of data. I think from some of the patients that elect to come and do rehab with us. So I can say that some of the patients are undergoing that therapy, not necessarily kind of as prescribed by the PT guys, but it's not like there's not like an official protocol for that. It's just that they think, if somebody might benefit from it or can tolerate it.
Yeah.
So I think it's going to be a little while of kind of collecting how are these folks doing before we can really make that sell, I think.
Well, we need that done. Kyle's basically a postmenopausal sarcopenic body type. And so he's dying for that kind of research because he needs whatever he can, man.
Yeah.
I think just outside of surgery, that could be a not a bad approach for that population that's at risk of osteoporosis and fracture, particularly given the findings we had in terms of the bone. So
yeah, I want to get into that. And basically, this Parkinson trial, it's not out yet, but the conclusion was it was really impressive what we saw in a month. That maybe they come in for 1 month in a year just to kind of get this vascular and kind of strength tune up. It's pretty interesting, and their functional measures improved as well. So that's an approach I want to go after. So let's roll into this ACL study. Badass study. Congrats, man. It sounds like it's about to come out in publication, we hope. And so just want you to share what you want to share. You've already presented it at AOSSM. And so we've talked a lot about it. But you want to go over kind of what the study was and what you can share?
It's in review right now. And basically we took a group of, we did a randomized trial where we had two groups, one of 16, one of 17 patients. Or maybe 2 of 16. I'll have to check that from the paper. But essentially what we did was we had one group randomized into standard of care ACL rehab, and then the other group that was randomized into the same exact rehab protocol, just with the addition of BFR on select exercises. So things like quad sets, single leg press, and it was all progressive in intensity from beginning to end. We did DEXA scans on them, total body to get the limb, as well as site-specific scans of the knee before surgery at 3 and at 6 weeks and 12 weeks of rehab. We also did functional measures on them, and then also measured follow-up time to return to sport activity. So this is mostly comprised of athletes, in terms of who participated in the study. And then following the study, just found that only the control group was found to have significant decreases for the most part in muscle mass, whereas the BFR group was found to pretty much maintain their muscle mass throughout the course of rehab. The other part of it is bone, right? Because now you're not mechanically loading as much anymore. So that's something we worry about as far as like postoperative fracture risk and failure potentially of the graft. So what we saw after they did their program was that compared to the control group, the BFR group had significantly better preserved bone. And that's not only at the whole limb, that's at the femur. When you isolate the femur, it's also down there at the distal femur and proximal tibia, kind of around where your sites are that you're doing your bone tunnels. So that was a big one for us, because that was the first time we've seen anything with bone and BFR. In general, though, from a physiology standpoint, that's a new finding for BFR. It's not an entirely new finding for just resistance exercise in general, only in that if you do something to stimulate muscle, bone is going to follow along a little bit slower, but it's still going to follow along. Mm-hmm. So it was neat that in the absence of being able to heavily mechanically load these folks, that we were able to have some sort of preservation effect. Right. And then not whether it's directly a result of that or not, on average had a 1.4 month reduction in return to activity, return to sport. So, and the people giving the physicians giving the clearance for that were blinded to study group. So, so the findings are pretty cool. The only thing I wish, the challenge in the study is that we were only able to do functional testing at week 8 and week 12. It's not like we can take people and do a bunch of functional testing right after surgery, right? Obviously,
week 4 or something, yeah.
Obviously, you can't do that. So we were only able to really capture that 8 to 12 week window, and I just don't. So we didn't really see any difference between groups there. But the problem is they've already been in rehab for 2 months, so you don't really know what the change was across that time. It just is a limitation of just the nature of the surgery and the timeline as well. But the results are pretty encouraging, particularly the bone stuff. I think the next phase from there, there's a few areas we want to look at in terms of what's causing that signaling mechanism for bone to grow, and then 2, does it work in a similar manner for other types of surgeries? So we have a study going right now looking at Achilles repairs, and also looking in the upper extremity, looking at like distal radius fractures as well. This also gave us some interesting thought into potentially looking at this in the realm of stress fractures. Mm-hmm. So that's kind of where we're kind of headed now, kind of in that DOD spin of things. Because I think that could significantly increase timelines for getting some of those guys back, because the military spending so much money per year on brand new guys that they then can't use.
Yes, big time. Well, and having dealt with a bazillion of those in the DOD, you've got like several months of a time course of doing nothing. Right. So then they just atrophy. I mean, they're basically unloaded. So they go to hell, and you're waiting on the fracture to finally heal, and then you start rehab after that. So you're already like 4 months in till you're finally trying to clear them. And it's almost always a new recruit who doesn't really have that time to lose. Yeah,
and then you're clearing them to go back to whatever got them there. You know, you have to get them reconditioned for that sort of a thing. So I think
halftime we weren't getting them back because they had to just go back.
Right.
And if they go to a frank fracture, especially at the hip, they're done. They were kicked out. You're lost. Right. And then you pay disability forever on that person. They're hardly served at all.
Right. So we're working on that. I think is an area, particularly in some kind of more of the sport populations, where that's a common. You see that commonly occur. And so that's kind of where we're kind of following the bone stuff with all of this at the moment.
But dude, to say in this study, you showed preservation of bone and faster return to play. That's badass, man. I mean, that's like, because your other things we expected to see strength and, hypertrophy and things like that goes along with like Luke's NHS ACL trial. He showed pain was better and swelling and range of motion as well. But you combine that with what you see, we're starting to really peel the onion back here.
Yeah, and I think based on there's a study that came out recently where they kind of did post ACL rehab or late ACL rehab high intensity stuff with BFR. Didn't see a whole lot with it, but I think to me what the combined results show is that if you can get them on it soon, after surgery, you can actually save yourself quite a bit of having. You don't get as far down in the hole.
Yeah. That was a Michigan study, and it took way too long to start. And also, heavy load with BFR just isn't something that you need, for sure.
Well, it's when you're already at like max recruitment, pushing max force. How much further. If you did that and then went down to like say 40% and then burned out, maybe that, but yeah, it's kind of like a diminishing returns at that point.
You used 80% limb occlusion to start with on everyone in this one
for the lower limb. Yeah.
And then I know you in your upper extremity, you do a 30-15-15 failure protocol. I can't remember on this one. Did y'all do that on this one?
Yeah, for our shoulder stuff. For the ACL study, we followed the 30-15-15-15. Okay. And that's we're talking about rehab there, and we're talking about also wanting to not go to failure or fatigue just from a standpoint of risk, but also the goals are different, right? The goals are just more getting function back. I think with our shoulder stuff. So I'll kind of preface. Do you want me to kind of preface with the shoulder study?
Yeah, man, go for it.
Can I ask an ACL question first, though? Because I just a point of clarification, because I'm sure we'll get asked this at some point. So, did the subjects in that study, were they cleared to return to play, or did they actually return to play?
Cleared.
1.4 months. Cleared.
Cleared based on their physician assessments.
Okay. So like an in-office hop test,
right,
that kind of thing. Okay. Yeah. Good. Okay. Just a kind of an important point, like in our world, people kind of ask that. So
people get all worked up. It's before 9 months.
Yeah. Right. Thanks so much for tuning into the Owens Recovery Science podcast. If you like this podcast, you like the content, if there's stuff you would like for us to cover, questions you have for us to answer, if you send it to us and we use it, we're going to send you a t-shirt. So that's a bonus. But also, we'd just like to know what you'd want to hear. So send that our way via email. That address is info@owensrecoveryscience.com, or you can send it to us via DM on social media. If you want to learn more from us at our in-person courses, go to our website, owensrecoveryscience.com. Click the Get Certified tab at the top, and you'll see a drop-down of where we'll be all throughout the U.S. and internationally. If you have not picked up the independent study course from the Academy of Orthopedic Physical Therapists that we wrote, please do so. Go to orthopt.org, and you can purchase it there. It's part of a 3-part monograph series covering blood flow restriction exercise, sleep, and nutrition. And so very kind of informative and certainly pertinent topics for rehab professionals, no matter what setting you practice in. So grab that, give that a read, let us know what you thought. And we hope you enjoy the rest of the podcast here with Brad Lambert of Methodist Houston.
Yeah, well, let's roll into the shoulder, man, because that one's badass too.
So, yeah, that was an interesting one because at the time, which was about, I'd say, 1.5 to 2 years ago, when we think about BFR, we're occluding muscle downstream from the cuff. So in theory, the magic that we are trying to focus on, or the anabolism, or these effects that we're seeing, is distal from the cuff, predominantly. From a rehab standpoint. However, we started getting calls and messages, more so our physicians, Dr. McCulloch, about baseball players taking this stuff and doing it for their shoulder, taking BFR and doing it for their shoulder. So initially we were kind of like, well, why? Because it made sense if you're saying coming back from Tommy John or something like that. But it seemed odd for the shoulder because obviously you're not restricting the blood to the shoulder. So we said, okay, we have a situation where we have this bandwagon thing happening now. And it not only in using, like, say, the automated units, but it was around the same time you saw this stuff popping up all over online, where
Amazon and
where essentially people are strapping toe straps to themselves because they think it's causing all of this stuff, for some of the stuff that we're saying earlier. So we said, okay, let's look at it. Let's see if there's anything there. Because what, at the time, as we were sitting around the lab table, is myself, Corbin Hett, and Dr. McCulloch. And one of the things we kind of thought, okay, well, maybe because when you're doing rotator cuff exercise and shoulder exercise, it's very hard to isolate those muscles. It's pretty difficult. In fact, you have to kind of do some odd things to get those things to isolate while you're training them. So our thought was, perhaps if you can fatigue out the muscle that's downstream from the cuff, maybe there's something that causes the shoulder to engage more when you're actually doing that activity, and you get more work done for fewer reps. So that was our initial thought. And then, so we said, okay, well, let's do a study on it, and let's start with just general population healthy people who aren't regularly weight training. We'll do it the controlled lab style, where we just put them through. We decided to do an 8-week study looking at rotator cuff training. Just 4 simple exercises: external and internal rotation at 90 degrees, dumbbell scaption, and then a dumbbell side-lying external rotation. Very 4 simple exercises that somebody could come in and do on each arm for 20 minutes. So we put them through the 15-15 fatigue protocol. So the fatigue part's important because at the end of the day, if you're doing this to train for just preventative purposes, not really coming back from injury, at the end of the day, if the answer was just doing 5 or 6 more reps, that doesn't warrant buying a device. It just doesn't. If it wasn't any better than just doing a few extra reps, then
low load to failure,
then it just didn't make sense. And I think my critique of some of the BFR studies where they're comparing low load and they go 30, 15, 15, 15 without the cuff, and then low load 30, 15, 15, 15 with the cuff, it doesn't answer that question. It just says using the cuff is a little bit better. But is it better?
I'm really happy to hear you say that, by the way. That tickles me.
Right. Yeah. So is it better if they just did a couple extra reps, which makes, then that warrants you not having to pay money for a device, which again, for professional athletes, it's not a big deal. They can buy like 20 of them and it's not a big thing. But for, like, say, a university or a small school or something like that, those people have to think about those costs. So, or like a small PT clinic. So that's what we did. And to look at shoulder activation, we also wanted to look at shoulder activation during exercise. So in this study, what we did was we had pre and post assessments of strength and endurance. The strength assessments were standard clinical shoulder assessments using an isokinetic dynamometer, like a handheld dyno. And then we also did a fatigue test using EMG on the shoulder. So we did anterior, middle, posterior delt, infraspinatus, teres minor. Some of the stuff you can't get to is surface EMG. So that's what we were limited to. And also trap. And then measured repetitions to failure and looked at EMG activation as they were going. We also did DEXA again, before and after. We looked at lean mass in the shoulder region. Obviously, the issue with DEXA is you can't necessarily get individual muscles, but you can get regional muscle. And then we also looked at the whole arm. And that study's in review right now by AJSM. And we've presented this stuff at conferences before. So essentially what we found is greater increases in muscle mass. Every set, the folks trained twice a week for these things, and we found that the BFR group progressed at a faster rate. They were increased in resistance by 1 pound every week. They could complete a minimum of 15 reps on their last set. If they got to that 15 reps, we said, go for it, and see how many you can get. Obviously, everything was form limited. I think that's the biggest thing.
Yep.
So form limited. In other words, if those elbows started popping out, if the arms started bending, if during scaption, if they started swinging or hunching in any way, the set was over and they've reached fatigue. That's something we have to be sticklers on with our baseball guys that are doing that, the second part of the study right now, because just they're athletes, so they try to cheat. So at the end of that, we had greater muscle mass improvements, greater improvements in endurance. The EMG stuff was the stuff that had us kind of interested as well, because what we thought we would see with the EMG was both of the groups start out at a relatively similar EMG amplitude for the prime movers, and then as they started getting to fatigue, we then thought we'd see an uptick in the BFR group, potentially, if our hypothesis was correct. However, we actually saw the uptick occur like right off the bat, right in the first few reps. They're already at a higher output and amplitude. So now we're kind of in the paper, we deal with some possible explanations for that. One of the thoughts we have is that just the act of having cuff compression on the arm there to begin with may give you some sort of additional stimulatory benefit, because you have sensing mechanisms right at the end of those muscles where they insert. So when you're talking about things that detect stretch and pressure in muscle, particularly with the shoulder, as it's this big multiplanar joint, right? So you have a lot of range of motion. So our thought is that just the compression itself causes the shoulder to potentially turn on more so than downstream muscle fatiguing. And that's kind of where we're at right now looking at it. We don't necessarily, I don't know on the arm if we can go so far as to say we're getting all of these local signaling effectors occurring. So in other words, stuff that's kind of dumping out of muscle as it's being occluded and then making its way back up through the shoulder. I'm not saying that's not part of it, but we think the shoulder being more active during the activity itself might be what's the prime mover of our study so far.
And there was a lower extremity EMG study that they looked at 40, 60, 80, and the EMG was much more distal. I mean, they had it all the way down towards the distal on the vastus lateralis and the rectus, and saw the same thing. Like first set, basically at 80%.
Right.
It was already up. So yeah, it's interesting. Was that a stretch response as well? Or, I mean, right. I'm with you. Like, I'm not sure if like first set, it's just like, boom, it's like, wow, everything just activated.
And it's, cause you see in certain situations, like tactile cueing can get used to get certain muscles to turn on, to do things, particularly in PT. You also have, there was another study where they had arm compression going on, and they got more, there was, I want to say they were doing press, like a chest press activity.
Yeah, it was Yasuda's chest press one.
Yeah, and they were getting a little more activity out of the chest when they were doing that. So I think there's something driving that. That's, I think, related to just the fact that the cuff is compressed. So what we're trying to look at now on that end, we've kind of split this into two directions. One area we're going to look at is doing other shoulder exercises and activities, so like kettlebell, bands, things like that, but at different cuff pressures to see if to see how that might influence things in the acutely in the upper extremity.
Yeah.
And because of our first study, we wrote another grant to Major League Baseball, who decided to give us the go ahead to look at this in pitchers. So we are very fortunate to have a very close relationship with the Rice Owls, and they have kind of really stepped up as an athletics department and are kind of, they're very much trying to move into a science forward way of approaching athletics. And so I think it was a good opportunity to work with some D1 athletes, and we're kind of in our second year of the study right now. So we're trying to see, you're talking about general population people, right? Who aren't really training. That's different than an athlete who's training all the time. The responses in muscle and someone who's trained are different than someone who's complete blank slate. And pitchers in general, as athletes, are particularly odd in terms of the forces in the stuff. Well, not just.
No, they're odd.
They're odd.
You're right.
They're odd.
They're
Yeah.
not athletes. They're odd. Exclude left-handers because you never know what you'll get if you got.
So not just psychologically, which, but in terms of the forces that they're subjected to, particularly at the shoulder. So we wanted to see if we could put them through the same sort of protocol, because in general they do this type of training for baseball anyway, for
Right.
shoulder preservation and so we wanted to basically apply our study protocol to them. And again, having a group with and without BFR, and we're looking at the pitching arms and basically putting them through the same thing and looking at DEXA as well. We're also tracking their pitch. We're also tracking their pitch counts, their velocities, their release height, and all of that, spin rates, all the general like baseball pitching metrics. Anytime we do a sports study, we always like to have some aspect we can relate back to the stats that those like coaches and players are used to looking at. The very big important addition to this study that we really wanted to look at is motion capture. So we're using a Vicon motion capture system to look at their mechanics before and after they go through the training protocol. Because here's the part that we're interested in. If you train someone and you put on a bunch of muscle mass, that's great for your average person who's interested in putting on a bunch of muscle mass. But these guys have to perform and they have to have range of motion, and they can't. And so we want to make sure that whatever we're doing, or we want to check whether or not it has an impact on their pitching mechanics beyond just training by itself. Because it could be that if we see some sort of benefit muscle and strength wise, but it's doing something that's negative to their pitching mechanics, that could kind of raise a red flag. So
That's good.
I think that's an important part, and where I could see it, what I see it being used for now, and I know you have some experience with some of these MLB guys doing some of this stuff, and where I could see it being used potentially in a college or pro setting is in kind of that post-game kind of post-game kind of like a flush out, or to make up for potential lost work. If you had a guy that was supposed to pitch 6 or 7 innings and he went out and got crushed after 2 and has to get pulled out of the game, well, now you've had all of this planned work on an arm that the arm is not going to see, and they're in your pitching rotation. You're having to deal with that. So, or if you're a reliever, you don't know necessarily. If you're a bullpen guy, you don't necessarily know. You're not always in on when you're going to be going in or being used. It gives you an opportunity to kind of particularly do some in-season maintenance, and then off-season potential strengthening and preservation. So that's where I could see it being used. I don't anticipate, just given the nature of the exercise, I don't necessarily see it as being some sort of like giant performance augmenting, but more kind of safety and maintenance. So
Yeah. Well, we're seeing a lot of it, and so we get tons of anecdotals in the MLB, and it's kind of very similar to your protocol. But I think it's like what you said. They already do this like post-throwers program, where they're lifting little, onesie, twosie pound weights, and it's almost like it's just lore. It's like, well, yeah, this is what you do after you throw. Right. You got to come in, and Nolan Ryan did it, and it was like, well, why exactly? And so, we just initially working with the teams was like, well, why don't you try it with a cuff and let's start seeing what you see. Now we got some pitchers, it's like life or death. They have to have it, they feel like it's doing something to their arms, but
so it's one of those things. We want to move it out of the place where it's like, even talking to some of the pitching coaches with those guys, they'll tell you if they think it works, then it works just because, but we're trying to move it out of the realm of, I guess, superstition and see, what is this actually doing? Because outside of the pros who have the ability to afford those kinds of like wants for certain types of things, I think you also get into some of these. Does it make sense for a D1 or a D2 to have one of these things kind of sitting back in the training room? Mm-hmm. Because you show that it preserves arms. And that's what we're trying to look at the moment.
Correct me if I'm wrong, but I think external rotation endurance was kind of like the big winner of your measurements, right?
Kind of cumulative, really, overall, as far as what they gained overall. In a one-time measure, we see a lot of internal rotation. But if you look at how they progress over time with the volume that they're able to achieve, because we track resistance and reps performed for each training session, so we plot it over weeks how they progress. You really kind of see it across the board. At least that's what we see in the healthy people. We haven't fully fleshed out in the pitchers yet. We're about halfway through with those guys at the moment. But the only other kind of anecdotal stuff I would say is right now, the challenge for us seems to be there's a general recommendation that we've had of starting at around 20% of their 1RM that we're getting off of an isokinetic test, right? We know the reps, we know what they're doing is not necessarily isokinetic, but we're using that because it kind of aligns with clinic protocols.
Yeah.
And I think after we get done with all these, may have some recommendations for the shoulder, depending on whether or not they're doing, like, say, a scaption or an internal rotation versus an external rotation. Mostly because you have there's other, for example, on an internal rotation, you have a lot of other muscle that can help you do that at 90 degrees. You have all of this stuff inside. You have deltoids. You have pectoralis. You have all of these things.
Yeah.
So you can manage intensities that are a little bit higher at the front end compared to, like, doing an external rotation where they actually are considerably a little bit weaker, even when you're talking about the same 20% of an isokinetic movement. Those external rotators tend to fatigue out a lot faster. So it may be adjusting those percentages based on what exactly they're doing. In general recommendations, but obviously from a rehab standpoint, and you're just trying to get people to kind of start going through those movements, it makes sense. I just think for the sport performance side of things and the preventative side of things, it may be worth kind of tweaking some of those recommendations a little bit.
Well, you're starting to move towards, what's optimal, like we have these recommendations that we make, but most of them are based off of quad and bicep,
Right.
Like nobody's even really looked at what's optimal for hamstring. Is there a different pressure needed for hamstring versus quad? There's still a ton of questions that we have out there on the exercise phys side, that would help our rehab because we would be able to dial things in a little bit better. So I think that's cool.
Even the 30, 15, 15, 15 thing, we're doing that because that's kind of what was done in the beginning, and we know it generally works as far as, like, those applications. But who's to say that's right. As far as, like, whether or not that's the best thing, that's not. These aren't like magic numbers that somebody came up with. Just know it generally gets the job done.
Yeah. Brad, did you guys have any pushback on putting the cuff? Because we get this question a lot, especially from baseball. Did you have any pushback, like putting the cuff on the throwing arm? And then do you have concerns in particular for, like, thoracic outlet? There's some folks out there in the baseball world that are really kind of concerned that maybe we facilitate some hypertrophy of the scalenes that we wouldn't normally get, or perhaps just the compression of the neurovascular structures would be problematic.
We haven't had. I don't think there's been any issue from the neurovascular side of things. 50% occlusion is not difficult for them to deal with. The hypertrophy stuff is an equal concern for me because I don't want to. Again, you don't want to manipulate somebody's mechanics into a harmful place, right? That's one thing I would say is, we have more people throwing very fast than ever before, right? But we also have more people getting injured. And you see in Tommy Johns happen more frequently. And so are we training ourselves into being able to throw fast, but also do that at maybe the expense of maintaining good mechanics? So I think that's certainly something we're thinking about. When we do these sessions with pitchers, we're doing them generally after they're doing a pitching performance. So the comment is always symptom limited, symptom limited, symptom limited. If anything feels like it's tight, stop. If anything feels like if you come in and you were throwing earlier today and your arm feels, it feels a little bit thrashed. Okay, let's cut the weights in half, and then you're going to do 2 sets instead of 4 sets. Or if doing a particular movement on a particular day is bothering you, we need to cut that back. So I think that's the big thing, is not being hyper married to a protocol, and keeping things consistent enough, but understanding, again, symptom limited is the biggest thing. Obviously, we don't want to do this with guys the day before they got to pitch. We don't want to do this with guys the day they have to pitch. They're concerned about their performance, and we're concerned about their safety. So we tend to find that with this group, the best time to get at them, where they still have plenty of time to recover, is on those days that they're pitching.
What's beautiful here too, you're a hardcore phys guy, and you can come at it from that angle. Part of the problems that we get is like, okay, this study found this, we get a lot out of the Scandinavian groups, but they had to do it twice a day for 3 weeks, and it's just clinically just doesn't happen. This is such an easy protocol. It's twice a week, okay, that's doable.
What they do in their sessions, they'll be in the middle of a strength and conditioning session, and it's just a station they go to, right? Yeah. It's just a station they have to be at for 20 minutes and get that arm done, and then get out. So it's not like, and additionally, these are exercises they're familiar with doing anyway, all the way since they've been in high school. So these are not new exercises to them. I would say the only other concern that we get generally is just in baseball as a sport, is what's going on outside of their normal standardized strength and conditioning program. And I think that is a challenge in the pros more than it is in college, actually, because you have everybody that's on there can be with their specialist doing their stuff. So as a PT, you have to make yourself, as a PT or a trainer, you have to make yourself aware of all of the outside things that guys are doing. Yeah. And that is sometimes easier said than done. At the college level, you're already dealing with strength and conditioning program that's there by the school, but it's keeping tabs on anybody who may be going out and doing outside things outside of that adds additional load onto those arms, because everybody and their mother has some sort of gym somewhere where they're a specialist in some sort of thing because they took an online class at some point.
And everyone thinks more is better, unfortunately, half the time. I just had a call with a pretty big time NFL guy, not directly him, but one of his trainers, who he's already doing BFR with this team, and now he's wanting to go work with his trainer and do it extra outside. And it's like, man, let's talk about volume here, dude. I think he's getting enough. Yeah.
And this kind of taps into not overdoing it, and getting guys to understand that recovery is as important as how much they train, particularly when you're talking about something like BFR where there's potentially fatiguing exercise involved. Mm-hmm. I think this kind of ties into what we had with our conversation. This is more of like a DOD type question, the value of being able to know what pressures you're using while you're doing things, and the amount of volume that you're putting in. And that's kind of where I'm kind of cautious about saying anything about some of these devices that you can just go online and buy and use. And then from a military standpoint, as well as an athletic standpoint, you have motivated people who are trying to get better in the, kind of no pain, no gain. And it's really, the concern is that somebody's going to do something at some point where they just kind of go a little far, like any kind of training thing. So I think that's why as we progress with the performance side of this, we just got to be careful, I think.
Sure. Just go back before I forget, the ACL study, that was twice a week?
ACL was twice a week. Yeah.
Twice a week. So beautiful. That's what ours are, all twice a week as well. So that's good. That's the question we get. How often do I need to do this? And I think most of our trials are set up for twice a week now.
And the other question we get is, are they leaving it? Are they doing it the entire time they're in there doing stuff? And the answer is no. It's usually what our PTs will do is they'll pick maybe one or two key select exercises that are maybe the big ones for the day, and those are the ones that they'll focus on with the BFR. So it's not like they're in there doing every single thing they do with BFR. It's kind of a progressive program that starts literally like for week 1, they're just sitting there flexing their quads, doing quad sets, out to where at the end you're seeing things like single leg lunge and leg press and single leg step downs and stuff that's more intense.
Nice. Well, man, congratulations. Badass couple studies. I mean, we're preserving bone, we're getting fast return to play, we're showing proximal. You're hitting all the ones that I want to show, man. You bastard.
It's one of it's one of those ones where it's the for some reason I keep telling myself every time we get done doing one of these chronic training studies or clinical studies that I'm going to stop doing these and just do the acute stuff. But for some reason I keep roping into them. So
no, we got enough acute guys. Keep doing what you're doing, man. We need more of you guys doing that.
Yep, I need like 5 more of me. So, as I'm like literally sitting here chugging monsters today.
Yeah, I noticed. Cool, man. So anything else you want to plug or talk about? You already touched base. You've got the Achilles trial. You've got a wrist fracture. Might be moving into the joints.
Yeah. The other some of the other areas we're interested in are just general. Again, on the DoD side, getting into kind of more of the more on the training side, looking at kind of general calisthenics with the use of BFR. There's those really nifty backpacks and stuff that hold 2 units and things like that. So obviously if people are out on site or deployed, it's not like they're around a training facility. What can people do to maintain their muscle mass and bone in those kind of hostile environments where they're maybe down, where they're kind of stationed somewhere where they don't have all of the nice necessities, but you can get a low weight device out there and maybe potentially prevent injuries and fractures that are even more of a problem if you have it on site while you're out there. So
downrange issues are bad. That's
so I think doing doing kind of more training studies like that, looking at general kind of body weight exercises compared to with and without the cuff, and then compared to more conventional resistance training.
Nice, man. Well, badass stuff. And it sounds like we'll just finalize this, but you and I will be presenting at combined sections virtually. So we'll get the final details, and you'll get to hear more about this and actually see some of the graphs and things as well. So
cool.
There you go, dude. It's good talking to you, brother.
Yep. I'll keep sending you stuff as we get it in.
Yeah. Send it my way. I love it. Stay safe over there in H-Town. Say hi to Corbin, Matt Holland, the rest of the group over there.
Wait. We can't leave. Hold on.
Oh, here comes a barbecue question or something.
Yeah. See, he knows. Like, Brad, come on. You're in Houston. What's the barbecue spot?
Well, unfortunately, I would have said like go to Papa's Barbecue, but unfortunately, a lot of like the spots that I would hit are unfortunately being like closed down due to COVID.
Yeah.
So
let's go back to pre-COVID utopian United States of America.
I really liked Papa's Barbecue out here, and here's the thing: right in the Houston area, I don't know that you would call that the place to get like the best stuff in Texas. It's like really like some of these like Austin, tiny
Central Texas.
Yes, and some of these tiny town like we're open for like 1 day a week type places, but we've been cooking it for like the last day. Yeah.
Cool, man. Well, anyway. I'm a big fan of Killins out in Pearland, I will say. I've been there once. It was good. I still want to go to Corkscrew, which I think is out in Spring.
It's funny because I'm gonna have some of my Carolina friends that are gonna watch this, and they're gonna comment that pork is a bigger deal than beef.
What do they know over there?
Got my Memphis barbecue shirt on, man, but I agree. Pork is only for wearing on a T-shirt like I'm wearing. Beyond that, stick to your cows. All right, man. Thanks, bro. Talk soon.
Brad. Appreciate it, man.
Yep.
All right, man. Later.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.